for the audience. So as Richard said, like, yeah, it's the topic is it's an old favorite. The Hodgkin's lymphoma is an entity that it has specific features, and it has stood up for centuries now. I'll be talking about Hodgkin lymphoma in general in basic terms. I have a couple of disclaimers. As mentioned by Richard, I'm not a hematopathologist by specialty. I'm a general pathologist, but I have an interest in hematopathology. You have to know that the subclassification of lymphoma is very dynamic subject and changes every a few years. And our reference, I referred here in this lecture to the WHO book, which gained lots of pages across along the last few years. But please, I urge you to continuously review the literature. The talk is based on the WHO. I will mention any differences in the ICC classification as I go, as you know that there are two groups, but the general terms or the general framework, I believe they are the same between those two groups. I will mention it. And you have to remember that lymphocytes, they don't read books, and they don't care about what you think they should like or do. So what we will be saying here is a general terms, general features, but each lymphoma likes to change one or two things of the general things that we see. Usually I start my lectures with describing how a normal lymph node histology will look like. The normal lymph node will have two main areas called the cortex and the medulla, and it has a sinus. They have sinuses. Though the patent sinuses is one of the features of a normal lymph node pathology. An intact capsule without extension of the lymph nodes beyond the capsule is also one of the normal findings. In the cortex, we see some germinal centers, and these germinal centers, so what we call a secondary germinal centers. And then we will see in the mixed population of cells in the interfollicular areas as well as the medulla. And there is also the hilum. Well, the hilum is like highly vascular and shows some fatty tissue. And there is an extensive high endothelial venules within the lymph nodes. Other cells that I didn't mention are the follicular dendritic cells and the interdigiting dendritic cells, which are present also in the cortex and interfollicular areas. So this is what it looks like in the histology. You have a capsule, sometimes well delineated nodules. The thickness of the capsule is dependent on how reactive it is. The long-standing diseases or long-standing processes will have a thicker capsule than just a normal capsule. There will be like a primary follicles as well as secondary follicles. And when we know how we know that it is a reactive germinal center versus a diseased one, we have something called polarity. So one area of the follicle will be darker than the other area, with maintained tangible body macrophages. Maintained mantle zone and then and marginal zone as well is a feature that we can see here in these lymph nodes, in these follicles, just to delineate a normal lymph node architecture. The other thing that I wanted to mention is the lymphomas in general. It's basically either a B cell lymphoma or a T cell lymphoma, and those are the most common ones. I know that there are other cell types, but the B cell lymphomas, either the maturation, like the journey of a B cell comes from the bone marrow and go to the germinal centers of a lymph node, but the T cells, like they start in the thymus and they go to the and they will go to the lymph nodes. Then what we will be mentioning is that the Hodgkin lymphoma per se, as I go through, it is considered even in the WHO book under the B cell lymphomas, and basically like the germinal center type or the germinal cell type lymphomas, and that's why we consider Hodgkin lymphoma it's like a diseased B-cell disease. Again, I won't go into details, but just to know that the markers that we mentioned throughout our throughout our lectures are actually like the either transcription factors or cell membrane receptors that will change along the maturation from the bone marrow to the lymph node or the germinal center, and if you understand how the changes are is happening through the lymph node, you will understand which markers are which, and which markers will be positive or negative in any lymph node. The samples that we get in a lymph node, if you are in a service that will receive a hematopathology, you will receive lots of samples, either an FNA cytology, but it's not the best in assessing lymphomas. We're just lacking the architecture that we see in usual lymphoma. There is an EUS guided biopsy that's okay, but it's in between cytology and core biopsy in the quality. The core biopsy is becoming more popular and challenging, and we are seeing it more often in these days. So become familiar with the core biopsies. I think this is it's important because that will be the what you will be assessing for the next in the next few years. But excisional biopsy will remain the gold standard for these for assessing the lymph node architecture. When we talk about the lymph node core biopsies, it's important to assess the adequacy of the cores, and you can imagine this is just a theoretical core biopsies through the lymph node that I showed you earlier. So if we've taken cytology, we are just sampling multiple tissues from multiple areas of the lymph node. But if we've taken like a core 1 biopsy, for example, we will just be sampling the interfollicular areas only, without much architecture of the follicles to see. If it's a core in core 2 biopsy, if we sample it, it will be like assist as an interest or like as an adequate core, because it passes through the capsule, follicular areas, interfollicular areas, and multiple follicles are ideal. But that's why we don't make a huge diagnosis on one core biopsy. Only 2 or more core biopsies are ideal for a full assessment. Example number 3 is inadequate core biopsy that goes through the capsule. So we aim to have more of 1 or 2 of core number 2 likes, so we will gain a good assessment. This is the general map. So if you have a biopsy happening in the lab, you assess it if it's adequate or inadequate. If it's adequate, you see if it's neoplastic or reactive. If it's neoplastic, you will see if there are non-hematolymphoid malignancy like metastatic disease or a lymphoma. And then the lymphoma, the big umbrella is either Hodgkin or non-Hodgkin lymphoma. And that's what we will be talking about here, like a Hodgkin lymphoma, the classical Hodgkin's lymphoma, or the nodular lymphocyte predominant Hodgkin lymphoma. And as I mentioned before, I based my talk on the WHO, and that's under B-cell neoplasm. And there is a chapter called Hodgkin lymphoma that will include classic Hodgkin's lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. And here it's worth mentioning that the term so like they are 2 different entities, 2 biologically different diseases. And the nodular lymphocyte predominant Hodgkin lymphoma tend to be a more, the prognosis is better, and the disease survival rate is higher. The staging at the time of diagnosis is lower. So that's why they trying in these days to remove the Hodgkin from the name, and you will be familiar with the name nodular lymphocyte predominant B-cell lymphoma, and that will be used for the maybe will be used in the subsequent WHO, but they kept it as a Hodgkin lymphoma just to keep the research going on and capturing this and avoid any confusion. So just become familiar with this name as an alternative to nodular lymphocyte predominant Hodgkin, as a nodular lymphocyte predominant B-cell lymphoma. And the last thing in the general introduction that I will introduce is the lymphomas. The morphology of the lymphomas are, if you have a visual mind of what a lymphoma will look like, if you have sheets of small round blue cells, these have specific differential diagnosis of small cell lymphomas. If you have follicles or nodules, either follicular lymphoma or nodular lymphocyte predominant Hodgkin lymphoma. If you have sheets of medium cells, think of mantle or Burkitt's. Sheets of large atypical cells, think of diffuse large B-cell lymphoma, T-cell lymphomas, or anaplastic large cell lymphoma. But this is the pattern that we are after, is the scattered atypical cells in a reactive background. And this is a typical for classic Hodgkin's lymphoma, as well as other entities that we will be mentioning in this disease, in this lecture. So shall we start? And just to let you know, it will be a basic type of approach type of thing, rather than a heavy a clinical or epidemiological background. So I will be focusing on the practical issues. So we'll start with the classic Hodgkin lymphoma. Classic Hodgkin lymphoma, the general concept, what you have is isolated cells. That's atypical large cell in a background of reactive cells. That's basically it is. And these atypical cells come in multiple forms. The most common one, or it's the Reed-Sternberg cells. And the Reed-Sternberg cells, usually they are 4 or 5 times larger than the smaller lymphocytes nearby. They will have large nuclei. Usually the ideal one have 2 nuclei, but it can have more. And the nucleoli are red and staring at your eye, what we call like an owl eye appearance. So this is the classic picture of Hodgkin Reed-Sternberg cell. But they are not the only cells that you can see in Hodgkin lymphoma. The Hodgkin lymphoma have a Hodgkin cell or mononuclear Hodgkin cell. So similar to the previous one that we have seen, but they are one round cell with one prominent nucleoli, eosinophilic nucleoli. We call it Hodgkin cell. And you have sometimes lacuna cell where you have a surrounding halo around the capsule with some vacuolation of the cytoplasm, forming like a lacunae. Or sometimes you will have these mummified cells, which are dense cytoplasm and pycnotic nucleoli. So these are the hallmark, not the hallmark, I will not use hallmark, but these are the typical cells that you see in Hodgkin's lymphoma. So these are the larger atypical cells that you will be looking for. And then the other component is the background. So what you have in the background, you will have mixed population. It differs from different types. Different types have different constituents of the inflammatory cells, but the background is non-neoplastic. But it's important, Milou, for the developing of Hodgkin's lymphoma. And most cases have a predominance of T cells with variable numbers of eosinophils, as we see here, the pink cells, variable numbers of neutrophils, as well as plasma cells. And histiocytes, plus minus forming granuloma. And that's it. Now you know everything about classic Hodgkin's cell lymphoma morphology, and you can diagnose them safely. The second thing that we wanted to know that is on cytology, it's very hard to identify these cells. And usually we discourage making a diagnosis of Hodgkin's lymphoma on a cytology specimen. It needs high level of suspicion, high level of clinical correlation. However, it might be useful in some cases of relapse disease or diagnosing of a relapse of Hodgkin's lymphoma, where an excisional biopsy or core biopsy might be difficult. So then an FNA can be accepted. This is an example of a case that a smear was more or less sufficient to diagnose a Hodgkin lymphoma. So we can see the smear is moderately cellular, and we can see these large cell populations, some of which are mononucleated, but yeah. And the background of these cells in a different core show a mixed population of neutrophils as well as necrosis. So that was easy to make a diagnosis of, and some neutrophils as well. So that made it easy to make a diagnosis on these biopsies. Okay. Now coming to the fun part, the HRS, like the Reed like Hodgkin Reed-Steinberg cells, are the typical immunoprofile that they are usually CD30 positive in the basically all the cells. They CD15 the majority of the cells are positive, but can be focal or patchy. But concurrent CD30 and CD15 expression is highly suggestive of Hodgkin lymphoma. And then the added features are the PAX5. It's a weak DIM. PAX5 is a B cell marker. It's a nuclear marker. So weak or DIM expression is seen in Hodgkin lymphoma, and this is because, as we said before, it's a diseased or a defective B cell neoplasm. So these B cells will be weaker to express B cell markers, and that's why we have variable expression of multiple B cell markers, including CD20 can be positive in patchy cells, but usually they are negative. The other B cell markers that are usually negative are the OCT2, BOB1, BCL6, or PU1. But the OCT2 and BOB1, sometimes they will have a very weak expression in Hodgkin's lymphoma, and we see that. But negative staining will be just a good sign that you are dealing with a classic Hodgkin's lymphoma. The EBV, we will mention that it is associated, different types have a different expression of EBV. GATA3 can be expressed in 80% of cases, PDL1 can be expressed in 40%, and STAT6, we don't usually use it, but it can be expressed in also 70 to 80% of cells. The typical cells of classic Hodgkin's lymphoma are negative for CD45, and the B cell marker CD19, CD79, they don't express immunoglobulins. They're negative for plasma cell markers and T cell markers. But know that, as I said, they don't read books, so sometimes in 5% of cases, they can express some T cell markers, usually CD2 or CD4 more than CD3. The background population beyond these atypical cells is usually mixed population of T and B cells, depending on the subtype. And usually we see CD21 follicular dendritic meshwork, or dense retained staining, or at least regressed in some focal areas. And this is the typical staining pattern that we see in CD30. So it's a membranous staining, and with a dot within the cytoplasm, what we call it a Golgi pattern type apparatus pattern of staining. And this is also expressed, like CD15 will show a similar expression of cytoplasmic, but sometimes it can have some granular cytoplasmic staining as well as the CD15, but it's uncommon in CD30. And this is the panel that we usually say. So membranous pattern, positive staining for CD30. These larger cells, as we can see here, they are negative for CD20. Typically stain, like the CD45 is negative, and sometimes it's very hard to interpret CD45 because of the density of the background lymphocytes. But you have to see the pattern in multiple cells to identify, for example, in this area here, it's technically negative membranous staining between two cells. This is the weak PAX5. It's a so dim or weak PAX5, and if you have a comparison between this and the background dense population or dense staining for B cells, so this is the differential staining. So these are the larger cells, are the weak steroid Sternberg cells, and the background is the B lymphocytes. And you can see the difference between this pattern of staining. So with a good control, if you have a good working PAX5, you will have that differential staining. CD15, and we will mention it. Sometimes it's hard to interpret, especially in mixed cellularity, because all the granulocytes in the background can show positive staining for CD15. So you have to aim for the larger cells. CD3 is negative, usually in the background cells, and this is MUM1 strong positive staining. The other panel, if this is not conclusive, or like some of which are not conclusive, like we have to assess the EBV status. Sometimes we do OCT2 and BOB1, and as well as some T cell markers as a panel too. And this is just to emphasize on the point that you need to see what you're looking at. So you have to correlate with the HNDE and immunohistochemical stains. So these are the CD peri positive cells. They will be positive for CD15, and all the background rubbish that you see in the CD15, they are not true staining. So you have to correlate that this cell that I'm looking at the same area. This is the cell size, the important cell size, and the pattern of staining, the Golgi pattern of staining as well. So by that, congratulations, you know everything about classic Hodgkin's lymphoma morphology and the immunohistochemical staining, and you're ready to go for the next stage. So what are the histological variants of classic Hodgkin's lymphoma? There are 4 histological variants that we know. In the new WHO book, they mentioned that there is prognostically, they are not significant anymore. They used to have they thought that it has a clinical significance, but now it's not significant as a prognostic relevancy. But however, it's important to know these features because we need to maintain. You need to know your morphological pattern and your differential diagnosis, and to be able to identify different patterns of a disease. And also for the research purposes, like they kept subclassifying these lymphomas depending on their variants to see the clinical significance for later on. So the most common type is what we will mention is the nodular sclerosis type, nodular sclerosis classic Hodgkin's lymphoma. So what we can see typically is thick fibrous bands, ideally hypocellular areas, and then you will have rules of hypercellularity. And this is the typical picture that you see on core biopsies. Usually they are present as a mediastinal mass. Nodular sclerosis Hodgkin lymphoma have a predilection for young patients with more female predominance rather than male predominance. And these nodules are the cellular nodules that they will contain some RS cells as well as lacunar cells on a mixed cellularity background, as we mentioned earlier. Eosinophils, histiocytes, and neutrophils are common in this feature. Sometimes the larger cells will form sheets of cells. So this is what we call a syncytial variant, and it's not uncommon in nodular sclerosis Hodgkin lymphoma. The other things that we see in this are the capsular thickening as well as necrosis. So you can see here, this is the same case, a central area of necrosis and then the cellular areas outside. And within these cellular areas, you see the background. Sometimes we refer it to as a dog's breakfast. So it's a very much like a mixed population of multiple types of cells, neutrophils, histiocytes, as well as eosinophils. And you see these scattered larger cells, some of which binucleated, some multinucleated, or mononucleated, as you see here. So this is the typical nodular sclerosis type. We'll move to the other area. It's the mixed cellularity, classic Hodgkin lymphoma. What you see is E-phase architecture with no significant fibrosis. You allow some thin bands only, but you don't have just thin bands, but not thick fibrous bands. The USC frequent RS cells, there will be mixed background comprising small lymphocytes, histiocytes, eosinophils and plasma cells. Neutrophils tends to be less common in this subtype, and you will see epithelioid histiocytes or granulomas. It has male more than female predominance and more association with EBV. I'll show an example of mixed cellularity that have histiocyte, eosinophils, and plasma cell, as well as lymphocytes. So you can see here from low power, the overall architecture is effaced. So you can't see the follicles, you can see the capsule. Or you can see the capsule, but you can't see the sinuses. They are obliterated. And if you zoom in for any of the areas, you find these cells. The Reed-Sternberg cell, just highlighted by strong positivity for like a very prominent nucleoli, and the background is mixed population of cells. There's lots of histiocytes, lymphocytes, some plasma cells, and isolated eosinophils as well in this. So this is a typical feature of mixed cellularity Hodgkin lymphoma. If we see the CD30, it will highlight most of these larger cell population. And you can see the pattern of staining that we see here. It's like a membranous as Golgi pattern type apparatus pattern of staining. And in this case, it was an EBV positive staining, which confirmed the diagnosis. So that's an EBV either-ish positivity. And what you see here is the positivity in the larger cell population. Some small cell population in the background is acceptable, but the larger cell population are the cells that are positive for EBV. And just for comparison, CD15 will be showing this positive staining in the larger cells as well, confirming the diagnosis. All right, so that's the mixed cellularity. And then you will have the lymphocyte-rich classic Hodgkin lymphoma. It can be diffuse, it can be nodular. The hallmark of this is the abundant lymphocytes with no significant neutrophils or eosinophils in the background. So you don't see that mixed population of cells, mostly lymphocytes only. You will have compressed interfollicular areas and regressed germinal center, as you see here in this picture. So you will have these germinal center slightly regressed than normal, and the RS cells within you will find it within those larger nodules. And this one has a differential diagnosis of nodular lymphocyte predominant Hodgkin lymphoma, as we will describe or we will mention later. The last variant is the lymphocyte depleted classic Hodgkin lymphoma. Usually have a diffuse growth, but lots of pleomorphic HR cells. And the eosinophils and plasma cells are equally scarce and no significant fibrous bands, but there will be lots of fibrotic background. There is a strong association with EBV and HIV, and it's thought to be a spectrum with mixed cellularity, classic Hodgkin lymphoma, the mixed cellularity, when it loses more cells with more fibrosis, it will become lymphocyte-depleted Hodgkin lymphoma. So congratulations, now you know everything about morphology, immunohistochemistry, and histological variants of classic Hodgkin lymphoma. Now, I will be starting to mention the differential diagnosis list, but let's stop at this stage to see, is there any questions that I can address, or shall I keep going?
Thanks very much, Dr. Househ. There are some questions. There's one, should we have both CD15 and CD30? What if only one marker is positive? I think you've kind of answered that, but maybe some clarification on that point.
Yeah, so CD30 is, it's a must, it has to be positive, but CD15, at least a proportion of the classic Hodgkin lymphoma should be positive for it. And there is a mention of a CD15 negative classic Hodgkin lymphoma, but this is a very rare occurrence, and you have to exclude all other entities before making such a diagnosis.
Yeah. So thank you very much. I agree. We also find PAX5 quite helpful because the Hodgkin cells are almost always weakly positive for PAX5, and the differential staining between the weakly positive Hodgkin cells and the strongly positive infiltrating B cells is often very helpful. The other thing which you mentioned on your slide is that CD45 or leukocyte common antigen is negative in classical Hodgkin lymphoma. And I know you're just about to come on to the differentials, but many of the differentials for classical Hodgkin lymphoma will be positive for leukocyte common antigen. So that also is a good one. CD15, I agree, is often weak, maybe patchy, and sometimes just negative. But see, and yeah. The other question is, what is meant by compressed interfollicular areas? This was in lymphocyte rich. Yeah.
Yeah. So the as you can see here, so it forms like it's basically forming, especially in the nodular variants of this. So the neoplastic cells will be abundant around these residual follicles, and they will expand to regress this normal mantle zone and marginal zone, as well as the interfollicular areas. So we see that the nodules is expanding in the expense of the interfollicular zones. I think that's what I mentioned. I meant.
Thank you. And that's really good. I must admit, I hadn't appreciated the presence of the regress germinal centers. So that's one thing that I've learned as well. So thanks. We'll let you carry on with it with the next bit. Hopefully, I'll learn even more. Thank you.
All right. All good. Feel free to comment on anything, Richard. Yeah, you're an expert as well in this field. All right, so we'll go to the differential diagnosis list of classic Hodgkin's lymphoma, and I'm mentioning classic Hodgkin's lymphoma per se because this is what we mentioned, and I will go systematically. I will show examples when I have it. The most common thing that you need to differentiate between, like at Hodgkin's and the T-cell histiocytic rich B-cell lymphoma, they have an overlap mostly with nodular lymphocyte predominant Hodgkin's lymphoma, and we will mention that later on. But it can be a differential diagnosis for mixed cellularity or lymphocyte rich. But as we mentioned earlier, this is considered technically a B-cell lymphoma. So these larger cells should be essentially negative for CD30 and CD15, but positive for CD45. And the like B-cell program, all the transcript like PAX5, OCT2, BOB1, and CD20, usually they are very strongly expressed in these cells. Technically speaking, to make this diagnosis, these large neoplastic cells should represent less than 10% of the cell population that you see. And the background, you will have histiocytes as well as small T lymphocytes rather than B lymphocytes, and this is important. We will mention that later on. Other differential diagnosis, and this is very important not to miss, is the infectious mononucleosis. So like this is a relatively treatable disease. It's not a neoplastic process, but it is an EBV associated. However, on the histological level, it can mimic Hodgkin lymphoma. And if you're not aware of it, if you don't think of it, you will easily miss it. Usually the tonsil is a very common location for this enlarged tonsil in a young population, in a young patient, usually male. What you can see is how you can differentiate between this and Hodgkin lymphoma. There will be less distortion of the overall architecture, and you can still see the follicle, slightly regressed follicles, but you can still see them. However, you can still see necrosis, as well as some fibrosis, but not thick fibrosis. The paracortical expansion will have immunoblasts, and sometimes they can look like HR cells. So these are the cells that you need to differentiate. And the background, there will be small lymphocytes, usually CD8 cells, and some plasma cells. However, how to differentiate the larger cells in infectious mononucleosis will be CD45 positive. They will be CD20 strongly positive. So these are the main differentiating factors. But be careful that it will be CD30 and either H positive. However, CD15 is usually negative in these diseases. And this is just an example to see how these germinal centers are more or less easily identifiable. And you can see how this can mimic a nodular, a lymphocyte-rich classic Hodgkin lymphoma. However, the background population or the interfollicular areas, they don't have the typical RS cells. They're usually large cells with one or multiple prominent nucleoli resembling immunoblasts rather than RS cells. All right. The other differential diagnosis for classic Hodgkin lymphoma is technically a common entity, is a diffuse large B-cell lymphoma with or without EBV positivity. And particularly, I will mention that if the diffuse large B-cell lymphoma have a pleomorphic variant or a pleomorphic or anaplastic variant as well, like with a lot of large cells, they will resemble RS cells. The EBV positivity will just add to this confusion with classic Hodgkin's lymphoma. However, how you differentiate between these two entities, there will be no eosinophils, no abundant T cells or rosettes. There will be technically diffuse population of B cells, and the B cell immunophenotype is fully expressed. There will be CD45 positive and CD50 negative. This is an example of a diffuse large B cell lymphoma that if you don't think beyond beyond the diagnosis, in a wide, with a differential diagnosis, you will miss these cells. So this you can see here, there are large cells with prominent nucleoli, some of which show multilobulation, and you can see some of which show very prominent nucleoli. So these can easily look like mononuclear Hodgkin cells, or even here you can see a smiling cell actually with two prominent nucleoli. So on morphological basis, you can see that this can be confused as a Hodgkin lymphoma. In these cells, just to add to the confusion, it can express CD30. So this is CD30 expressed in some of these cells. But you can see they are it's variable degree of expression, with some larger cells are totally negative for this entity for CD30. And if we can see CD20, it's diffuse. It's highlighting all cell population, all the larger cell, and so this is it's forming sheets of cells. So this is considered as a diffuse large B-cell lymphoma. CD50 it was negative, so that was helpful in determining that this is just a diffuse large B-cell lymphoma. And just to add, the CD45, the PAX5 in this case, it was helpful that these PAX5 show very strong positivity rather than weak positivity, which indicate a full expression of this. So this was a diffuse large B-cell lymphoma. Other differential diagnoses for classic Hodgkin's lymphoma, especially in the mediastinum, are the primary mediastinal large B-cell lymphoma. They usually mature B lymphocytes. They will have expression for CD30, but just focal, and they will be usually CD23. They look like diffuse large classic Hodgkin's lymphoma because they will have stromal sclerosis, but sometimes they express some specific markers that the Hodgkin lymphoma they don't express. And if we look at an example of primary mediastinum large B-cell lymphoma, they can look like a Hodgkin lymphoma. All right, so you will have large nodules, you will have some fibrosis in the background. However, the large cell population, so the population of the cells, they are not typical RS cells, but rather like B cells showing some immunoblastic type morphology. And on immunohistochemical level, they can express CD30. So you can see the expression. Again, as we said, the expression of this CD30 is it's not consistent, it's weak, it's patchy with variable staining, mostly weak. And this case was strongly positive for CD20. So this is a primary mediastinal B-cell lymphoma. It was in a young patient. And just this is an added, the PD-L1 expression is very strong in such cases, which an added desirable criteria to diagnose this entity. The other differential diagnosis for classic Hodgkin lymphoma is something that looks like that has features between nodular lymphocyte nodular sclerosis, classic Hodgkin lymphoma, and primary mediastinal B-cell lymphoma. And this is very difficult, actually. They call it like a mediastinal gray zone lymphoma. They can express CD30, but as we said, it's mostly heterogeneous. The CD15 usually negative in these cases, but it will show some features that will look like a classic Hodgkin lymphoma. And this is, we discourage making this diagnosis on core biopsies unless you don't have any other, because this is one of the core biopsies that we raise the suspicion of this diagnosis, and then we confirm it on an excisional biopsy. But you can see that there will be lots of overlapping features. So you can see so mixed population, mainly histiocytes, as well as small lymphocytes with cells that have a prominent nucleoli. And these cells, they don't show the like expected expression, full expression of CD30. So CD30 was weakly positive in most of the cells. The CD20 was also weakly positive in some of the cells. Let's see. It was expressed in a population of cells, but more than what we can see in T-cell rich, histiocytic rich B-cell lymphoma, and CD15 show very like a negative expression in these cells. If we see here PAX5, so these are difficult cases that they will need like to do a full panel, but you see like a strong expression with some variable expression in some of the background cells, but the background population doesn't look. So yeah, we ended up having a full panel that with features between classic Hodgkin lymphoma and primary mediastinal B-cell lymphoma. So CD45 also was negative in these larger cells. So we ended up calling it a mediastinal gray zone lymphoma. Other diagnoses that you can mix with a classic Hodgkin lymphoma is the nodal T follicular helper T-cell lymphoma, either in angioimmunoplastic type or other B-cell types. They can have lots of reactive B-cells in the background, and they mimic Rh cells. EBV positivity is not uncommon. It can be positive, especially in the angioimmunoplastic type, and can be positive in CD15. However, these the larger cells are strongly positive for CD20 and other T-cell marker. I'll just show the immunohistochemistry of one example of these angioimmunoplastic T-cell lymphoma, or like nodular TFH T-cell lymphomas. They on macroscopic level, they will have that mixed cellularity in the background. They will have high endothelial venules, and the larger cells are the cells that are usually B-cell positive and EBV positive, and the background population is usually T-cell. The CD30 can be positive in a proportion of this larger cell in the background, which will add to the confusion of this picture. I'll just show one example that this one of the TFH marker, that's the CXC13, that's strongly positive in the background T cells. Other differential diagnoses that you are aware of and you should not miss is an anaplastic large cell lymphoma. These cells are usually large cells in the mixed population in the background. The hallmark cells are kidney-shaped cells, but they can form like a full ring of cells, what we call a donut cell. Some necrotic neutrophils or apoptotic neutrophils can present in the background, as well as necrosis with eosinophils. So these cells are this can look like Hodgkin lymphoma, but in comparison to Hodgkin lymphoma, these cells should show strong sheet-like cells, CD30 positive cells. They usually CD45 strongly positive. They usually CD4 positive, as well as EMA. It can be ALK positive or ALK negative. This is an example of an ALK positive case. And the B cell markers ideally should be negative, and PAX, including PAX5 in these larger cells. The ALK negative ones are usually either nodal or extranodal. They will express some of the T cell markers, but some of them they could have like the null type, so they might not express some of the T cell markers, which will add to the confusion. I'll not go into details into this. Just the last thing to mention that peripheral T cell lymphoma NOS can have some CD30 positivity. So just keep it in your mind that screening with 1 or 2 T cell markers can be beneficial in such cases. So this is an example of a case that was diagnosed as a T cell lymphoma with peripheral T cell lymphoma with the CD30 positivity. So you can see the mixed population of the background cells, including neutrophils, apoptotic bodies, histiocytes, but you can see sheets of these large atypical cells. And if we look harder, you look at cells that will look like Reed-Sternberg cells. This one, I'm just showing CD30 just to tell you that CD30 is not a lineage marker. It can be positive in lots of cells, including these cells. So yeah, scattered cells show that pattern of membranes and Golgi pattern type apparatus, and we ended up calling this peripheral T cell lymphoma rather than anaplastic large cell lymphoma because this pass of the CD30 positivity. Ideally it should be block positivity, strong positivity if we're looking at anaplastic large cell lymphoma. And that's it. Now you know a lot about immunohistochemistry, histology, and variance and differential diagnosis of classic Hodgkin lymphoma. I still have the classic like nodular lymphocyte predominant Hodgkin lymphoma. If I have 5 minutes, I can go
certainly.
through
Absolutely.
quickly.
Yes. Thank you.
All right. So the nodular lymphocyte predominant Hodgkin lymphoma or B cell lymphoma is, as we said, it's a different morphology, different entity. They will withdraw the Hodgkin diagnosis or like word from its diagnosis like soon. It's 3 types of cells. You have the large atypical cells, what we call a popcorn cell, that is multilobulated vacuolated cells. You have background, and these cells show strong positive staining for B cell markers, and this is unlike the other classic Hodgkin lymphoma, can be positive for CD45 as well as BCL6. CD30 and CD15 can be seen, but it's usually negative. And either-ish can essentially negative. The CD20 show 2 patterns of staining. So the large cells are strongly positive, as well as there is a background cells, what we call a mantle zone B cells. And these background B cells, they show staining for IgD, CD23, and TCL1 staining resembling mantle zone. And the third component we will have, these are the T cells that will form the background T cells, which are follicular helper cells in immunophenotype that will be essentially positive for CD3, CD4, PD1, and CD45. So how to differentiate between nodular lymphocyte predominant and a lymphocyte-rich classic Hodgkin lymphoma? As we said, CD15 and EBER are negative in nodular lymphocyte predominant. CD45 is usually positive. So, and this is PD1 staining, as you can see here. This is CD20 staining. And the CD21 is a good, I don't have that example here, but usually it shows expanded follicular dendritic meshwork in nodular lymphocyte predominant Hodgkin lymphoma. I'll not go into details on this, but you have to know that there are 6 morphological patterns, and it's dependent on the CD20 availability of CD20. So patterns A to C, it's thought to be better prognosis than D, E, and F. So the first one is, then this is from the WHO book. They have a very good visual pattern type guide. Pattern A is a classical B cell rich type. Pattern 2 is Serban-just interconnected B cell rich type as well. Pattern 3 is the prominent extranodal lymphocyte predominant cells. Pattern D is a T cell nodular, so you will have nodules, and within these nodules you will have these LP cells and these rosettes. The pattern E is the problematic one. It's diffused T cell T histiocytic rich large B cell lymphoma like, or the diffuse large B cell lymphoma like picture, which is this is the most the one that you need to be know about the most. How to differentiate between these two entities? At least one unequivocal nodule is required to distinguish these two variants. And the presence of background B cells, this is common in nodular lymphocyte predominant Hodgkin lymphoma, these mantle zone B cells, that's usually not there. And the rosettes are, it's something that we see more common in nodular lymphocyte predominant Hodgkin lymphoma. The last pattern is pattern F, which is the diffuse moth-eaten appearance. I will not go into practice cases, but I will just show one last case of nodular lymphocyte predominant Hodgkin lymphoma pattern A. I will show. So this is a lymph node. So you can see the nodularity. You have bands of fibrosis, but not thick bands. And here you see beautiful granulomas surrounding these nodules. And this is very typical for this type. Can happen in classic Hodgkin's, but this is very common in this one. And if we zoom on one of these nodules, you will see that you have like large cells and with a rosette formation of smaller lymphocytes in the background. And this is a typical picture of nodular lymphocyte predominant Hodgkin lymphoma. I'll just show a couple of immunostains. This is CD20. In these larger nodules, you can see the CD20 staining the larger cells as well as the background cells. Maybe here, that's a good one. So the central cells, the surrounding cells are negative, and you have positive background cells. The CD21, this is the type of pattern like slightly expanded follicular dendritic meshwork, and this is the typical feature that you see here. And the last thing I want to show is the CD45. You can see that these larger cells are strongly positive for CD45. CD57 showing some rosettes around these larger cells. So this is how you diagnose. It's just clinical as well. Like it's on morphology alone, you can diagnose this entity. So the take-home message is classic Hodgkin lymphoma is a common disease and could be diagnosed on morphology if it shows classical features. Limited panel as CD30, CD15, PAC5, CD20, CD45 can help confirm the diagnosis. CD30 is not a lineage marker, so it's not, and it can be expressed even in some carcinomas. So just be careful of calling something on CD30 alone. It has to be a panel. Always check the history and the imaging findings, and always be greedy. Ask for more tissue. Basically excisional biopsies, and try to avoid making bold or rare diagnoses on just limited material. And the context matter. I have a theory that if you stare 30 minutes at a reactive lymph node, you'll start to see RS cells. So just be careful of what your mind games. I think that concludes my talk. If you have any questions, I'm happy to answer. And thank you very much.
Well, thank you very much, Dr. Househ. I mean, that was like, you know, an absolutely fantastic talk. I learned a lot there, particularly the different patterns of nodular lymphocyte predominant. Really excellent mix of kind of like background, science of it, features of each, the morphology, the immunohistochemistry, tips for diagnosis, and also all those differentials, because I think that's a key thing, isn't it? The differentials of Hodgkin's.
Exactly.
There are many things which look like it. One thing I find helpful in distinguishing T-cell histiocyte rich large B-cell lymphoma versus nodular lymphocyte predominant Hodgkin lymphoma is the use of CD21 follicular dendritic cell networks, which are seen in the Hodgkin's, but not in the T-cell histiocyte rich. Yeah. But otherwise, that was the only thing. I don't know if you mentioned that or not. That was the only point.
Maybe I mentioned that earlier. Maybe I didn't, but I didn't mention it in the key slides. But yeah, definitely. See, absence of CD21 follicular dendritic meshwork, it guides us to the T-cell rich B-cell lymphoma diagnosis.
So that was an absolutely fantastic talk. So I'll be